So our next speaker will be Devan Griner, speaking on updates in the management of craniofacial deformities. And we want to thank the Lawrence T. and Janet T. D. Foundation in memory of William Riley Brown, MD, for sponsoring this lecture. And just a quick note reminding you that at 10 o'clock we will have poster presentations, and that will be across the way. So, Dr. Griner.
Thank you very much. I really appreciate the opportunity to come speak to you guys. This is a great society, and it's great to see it so well attended. Craniofacial surgery is a huge field with a lot of variety, so I've narrowed it down to a couple of topics. But first of all, I've got no disclosures here. My background, when I was a sophomore in high school at Skyline High School, I got the opportunity to go on a medical mission with Operation Smile. And before that, I'd pass out every time I saw blood, and so it was surprising to me. This is the first time I was ever in an OR right here, and I did pass out about 30 seconds after this picture was taken. But seeing the transformation that happened on this mission is what set my course for my career and my life, and I've chased it ever since and never deviated from it. So I came home with a desire to be able to look blood in the face and not pass out. And I attended BYU for my undergraduate, University of Utah for medical school, went out to UNC for a full general surgery training, and then University of Tennessee in Chattanooga for my plastic surgery training, and then was lucky enough to be able to go to the Medical City Children's Hospital in Dallas, Texas for the probably the busiest craniofacial fellowship that we have in the country. So today I want to briefly talk about some updates in the management of cleft lip and palates, craniosynostosis, positional plagiocephaly, which we see a lot, and if we get time, some congenital ear anomalies. So cleft lip and palate, this is one of the kids from up here in Ogden that comes down to see me, is in Utah, the highest incidence in the entire country is here in Utah. 1 in 500 children will be born with some type of an orofacial cleft. So in fixing cleft lips and palates, our goals are to achieve normal speech as number one in my book, from the last presenter talking about job opportunities. If we have a child that's 15, 16 years old looking to get their first job, and then later on in life, if they have a speech disorder or hypernasality, velopharyngeal insufficiency, it's also been proven to show that they have a harder time getting jobs and moving up the ladder. So number one for me is speech, because any of the other stuff can be fixed later, but if speech isn't fixed by about 6 to 8 years old, it's very hard to get that back. We want to achieve a normal appearance, and we want to do this in the fewest number of interventions possible. We're starting to see children now being diagnosed with surgical PTSD, and a lot of the cleft kids in our state, unfortunately, have fallen into this, because I had one kid who hates summer, because he knows that every summer he's going to have an operation, and that's just been his life. And so these kind of things I'm hoping we're going to bring to an end by being smart about how we manage cleft care. So cleft is probably the most refined operation that there is out there. It's been studied forever. There's so many people doing it. There's so many nuances of it. It's been studied. Little tiny tweaks of everything is probably the most refined process out there, because it affects so many different systems. It affects the appearance, speech, hearing, eating, the dentition, psyche, as well as the psyche of the entire family and their friends. So because of that, the standard of care throughout the United States and in the world is a team-based approach to this. It's not one surgeon and they kind of farm it out. It has to be a team that knows what they're doing, is familiar with cleft, has studied in it, and can produce the outcomes and coordinate together. So here's the team that I put together when I came back, and we've got all of our speech therapists, we've got our dentist, ENT, oral surgery, orthodontist, me, our audiologist, and the most important person is the team coordinator, and they're the ones that keep everything in line. And it's really important that these people have experience and are certified. This is the American Cleft Palate Craniofacial Association. Will actually come out and certify teams. So we actually have 2 teams in Utah, or 3 teams, I think, in Utah now that are actually ACPA certified. So the goals in this, or the balance that we have to make in this is when we fix a palate, we found through studies that if we fix a palate too early, we can scar up the growth center of the bone and get mid-face protrusion. And that requires another operation to bring the upper jaw forward later on in life. However, if we operate too late, we don't get good apposition of the muscles in the soft palate, and they don't train that well, and we don't get good speech. So it's this speech versus growth dilemma that we're always dealing with. And for years, people have gone and tried doing it early, tried doing it late, doing different modifications to try to figure out what's the perfect time, and we've pretty well teased that out. So the American norms right now would be to start out with what we call alveolar nasal molding, where we just put some splints in to kind of get the nose ready for an operation. We do a cleft lip and nose repair, cleft palate repair sometime between 9 and 12 months old, alveolar bone grafting sometime between 9 and 11, and then possible jaw surgery and possible rhinoplasty later on in life. So that's kind of the norms in America right now. But in this balance of speech versus growth, people have come up with all different types of ways to try to do this. Many of you may be familiar with Dr. Morales, but he came up with an idea 20-something years ago to see, well, if we fix the soft palate just back here and leave the hard palate alone where the growth centers are, and then fix that when they're 4 or 5 years old, maybe we'll have an effect on the growth and we won't have to do as many upper jaw surgeries. But we want to have good speech, so they came up with the idea, we'll just take a piece of plastic here and we'll anchor it in through some spikes into the hard palate and just leave it there. And that was, a fantastic idea of trying to bridge the gap between those two. And so many centers have tried that throughout the United States and throughout the world and found that it just leads towards more surgeries. So the idea would be that all we're doing is delaying the hard palate closure on it. Unfortunately, this is an actual operative record of a kid that came in to see me the other day that's been in cleft care for, he is 14 years old. And so he has undergone, these are all separate surgical interventions, right? So each one of these is a separate surgery. So nasoalveolar molding, lip repair, soft palate, replacing the obturator because it came loose, replacing the obturator because they thought it was too small, another lip revision, and an early rhinoplasty, surgically assisted palatal expansion. These are all right here before 2 years old. Hard palate closure, all right, then an alveolar bone graft, a repeat bone graft, a halo distraction. They actually had another bone graft after that, a speech surgery, and the kid comes into our clinic, still doesn't have good speech, has mid-face protrusion and scar tissue like crazy. That's sometimes we get to these points, we call them cleft cripples because you just don't really have any more tissue that's not scar tissue to work with. So I'm calling this the new Utah way of what we're trying to bring it back to. This actually has been talked about throughout the nation of people calling because some of our patients will move and go out and they're asking, well, what's this whole Utah way that's going on? We're trying to bring this back so that we're not taking kids to the operating room so much. And so in our team and what our goals and what we do are hopefully most of these kids, 50% or more, should be able to get through an entire cleft lip and palate repair to the age of 19 with 4 surgical interventions. All right? But you have to be smart about it. You have to plan each one for the next step and what's going to happen, and you have to coordinate with everybody else on the team and maximize every time you go to the OR to get as much done as you can. So at 6 to 8 weeks, we do the nasoalveolar molding. That's not a surgical intervention. It doesn't have to be. There's different ways you can do it with a pin retained one for parents that live really far away that it's hard to come in twice a week. But the first operation can be at 3 to 4 months. We do a cleft lip and nose repair. We do a soft palate adhesion back here where we just take the soft palate and marry it together with a couple stitches. That keeps it together for when the kid grows, the palate widens. If you leave it open in the back, then that palate can get super wide, and when you try to fix it, there's too much tension. It can break down, you get a fistula, and fistulas are the bane of the existence of a craniofacial surgeon. So we do the soft palate adhesion. I do an alveolar adhesion up here, the gum line. I bring just the soft tissues together. That way when I come back to do my bone graft, I have a nice vascular bed. that's not scarred up, that has one bone graft that takes 100% of the time, and we're not doing repeat bone grafts on these kids, which can be super painful if we have to use their own hip bone for it. So then we do ear tubes at that time and a hearing screen ABR, all under one anesthetic, right? And then nothing more until they're 10 to 12 months old. Then we do a soft and hard palate repair, the entire thing. We bring the muscles in, right? The ear tubes are rechecked, and my goal is nothing more. The child has nothing more until they're 9 to 11 years old, when that permanent canine starts to come in. Now, bone grafting has to be done when the teeth are starting to erupt. If you do a bone graft and no teeth are coming in, you can get bone to grow for sure and stay, and within a year it will dissolve and go away because there's no bone to stimulate it to stay. If we took out all of your teeth right now, within a year, you would have no bone all the way up to your nerve roots, because you have to have teeth or something in place in order to stimulate that bone to stay in place. So we do bone grafts on these kids sometimes that I see with no evidence of tooth eruption, and it's a wasted procedure. So we time it with the orthodontist, with the dentist, to look when that canine root is 2/3 of the way down. When it starts to erupt, we go in and do the bone graft. If it's 8 years old, great. If it's 15 years old, great. We time it with the teeth. And the nice part about having that alveolus closed with soft tissue is then I can use off-the-shelf bone graft, and I don't have to use their own hip. And if I do that, way less morbidity to the kid, and it's a outpatient surgery. So, and that's at 9 to 11 years old. So that's the goal, and what we're trying to bring back and create this is the new Utah way. And so here's just a couple of kids that little Evelyn, and she's not going to have anything hopefully till she's 9 years old. She's going to love summers and not be afraid of them. Another little boy. So the goal with lip and palate repair now isn't can we get a good result. We can get good results. Now can we get good results and decrease the number of trips and anesthetics that these kids have. All right, so craniosynostosis is another passion of mine. Kids that are born with sutures in their skull that are fused too early. And we see a fair amount of this in Utah as well. Recent updates in this are that there's a lot of genetic findings. We're starting to find that there are actually genes that make kids more susceptible to it. And Yale just published another 3 genes on top of the 12 that they had found a couple of years ago. So we're starting to find that this can run in families more than we thought. And maybe it's a 2-hit phenomenon. Maybe you're a carrier of a gene that makes a suture more sticky, a little more compression inside the womb might make it so that that suture sticks and fuses. We find it a lot more often happening in twins or crowded wombs. So, in the treatment of craniosynostosis, the big controversy on it right now would be the type of surgical repair that we do. We all agree it needs surgical repair. So there's 2 different ways. There's the cranial vault remodeling, and then there's strip craniectomies. In the meetings, we call them the strippers versus the vaulters. So to understand and figure out which method is the best, you have to understand the physiology. There's more than just a skull here involved. The skull's only there so it can protect the underlying brain, which is way more important. So we have to take the brain into consideration for all of this, and not just how can we make a skull a different shape. So a fused suture will restrict the skull expansion radially in that entire area. Now, the other sutures can make up for it as the brain grows for a while, but that starts to slow down between about 18 months. So as the brain increases in size, it increases the pressure within that skull when there's a fused suture. When you have an increased pressure, you have a decreased blood flow. The decreased blood flow decreases the metabolic activity in the brain. You can get developmental delays. We used to quote that it was 40% of kids with uncorrected synostosis will have a developmental delay. It's now widely accepted it's 100%. Now that we're getting better at figuring out and being able to test different developmental issues. So vault remodeling required, I do this between 10 and 15 months old. It's a 2-hour surgery. It requires 2 nights in the hospital, 1 night in the ICU. I do this with no narcotics, no transfusions, which is a little bit of a lie, but we've gotten it down. It used to be 100%. We're down to less than 10% needing transfusions. And I do that by giving Procrit injections and using a cell saver. So in vault remodeling, you get an instant head shape change. You have not done, every time I'm doing a vault remodeling, I'm expanding the skull, so I'm increasing the volume, I'm overcorrecting it so that we have catch-up growth and that brain has plenty of room to grow and function. Blood salvage, like I said, this is my picture for Procrit, or EPO. These kids all get shots for about 3 weeks prior to surgery, increase their hematocrit, increase their blood volume. We also know that by giving EPO and Procrit, we actually make them so that they're more coagulable. In fact, in adults, we know that this can cause PEs, DVTs. It's never been shown that it can cause it in a child under 9 years old, so it's pretty safe to use. So we use that. We use a medication called TXA during surgery, and because we're using that, they bleed less. And then I've brought and have new protocols down here at Primary Children's brought in for Cell Saver that we use during surgery so that we can recycle the blood that's lost during the case, and less than 10% of my children will actually need a blood transfusion, which can increase risks for infections, increase risk for blood transmitted diseases, etc. So strip craniectomy needs to be done before 3 months of age. After 3 months of age, it's ineffective. People have tried it. I've seen a couple even recently in the last year here that have done older than that, and you just can't get the head shape from it. So it has to be done less than 3 months old. It's about an hour and a half surgery. It's 1 night in the hospital, no narcotics, usually no transfusions. But then the real effect of the head shape after that is by wearing a helmet for 10 to 18 months afterwards. So I recommend to parents when they come in and talk to me, I'll perform a strip craniectomy if somebody's, that's absolutely what they want to do and they've read and they know, and I'll do that. But I recommend a cranial vault remodeling over a strip craniectomy for these following reasons. First of all, it's less of a scar, but it's not less of a risk. The only death we've had in a craniosynostosis kid in the last 5 years here in Utah was with a strip procedure, and not the full cranial vault. It got into the sagittal sinus and bled. You get an immediate correction with a cranial vault. What I leave the OR with is the head shape that I'm getting. I'm not relying on outside forces and constriction and somebody else, an orthotist, to give me my head shape. The whole idea behind fixing craniosynostosis is to give room for the brain to grow, and if we're going in and putting a helmet on that constricts an area so that the brain can beat out the other areas, it doesn't make sense to me to do that at a young age on a kid and purposely constrict them in an area afterwards just so that I can get a good head shape. It's great to get a good head shape, but if they're developmentally not great, what have we done? So I don't like to rely on a helmet to give me that shape. We see a high incidence of refusions. So kids will come in with a sagittal synostosis, they got a strip, they come back in at 2 years old, and now they've got sagittal, bicoronal, and a lambdoid that's fused and need another operation. So if we know these kids are having genes that can make them more susceptible, and we know crowding can do that, and then I put a helmet on them to constrict the other sutures that are intact, it makes sense why we're seeing so many more refusions afterwards. The other thing is when they on a strip, you're taking the bone and throwing it away. On a vault, I'm taking the bone and redistributing it everywhere. When you throw away the bone, you leave a big gap, and you're just hoping the body will regrow bone there. So we get a lot of kids that come in that have a big critical size defect that have to go in for another surgery later, harvest bone from somewhere else on their skull to fill in the patch of where it was left. And then pediatric anesthesia. We've been told we shouldn't be doing procedures that we don't have to do under the age of 1 if we can help it. And so to have another option that I think is superior anyway, to try to do that later, or to try to do it earlier at 3 months old, doesn't make sense to me. And then the last, and probably I think the most important, is the intelligence data on it. So this was a study done out of Yale and co-sponsored with the group at CHOP in Philadelphia that came out a couple of years ago that was pretty evident of the results. The gist of it is that patients that underwent cranial vault remodeling had higher intelligence scores later on than those that went under strips. Problem is you also have a mom who lost a kid to an open vault, started a campaign, started an organization that inundates the internet right now trying to push people towards doing strip craniectomies. And so we get a lot of people that are really pushing towards that, and academic centers, unfortunately, that coincide with that. So. I don't do strips ever. If a patient comes into me and the parents want a strip, I won't do it if they're syndromic, right? If I know they have a genetic cause. So this should never be done in an APE or Pfeiffer Cruzon patient, ever. And if they have a genetic predisposition for it, no, never. So if there's any family history, I would never do a strip for it. And I don't like doing them anywhere in the exposed forehead, so metopic or unicoronal, because you just don't get the good shapes out of it afterwards anyway, and they have to have them redone so many times. So those ones I'll actually refuse to do a strip on, and they can go somewhere else. All right, next, real quick on positional plagiocephaly, which we see a lot of, and there's kind of a lot of controversy on. Can be of all different kinds of variations there. That's just a picture of what happens is the brain is beating against the skull. You can see where it thins out like that. The brain is what drives the growth of the skull by beating against it. In synostosis, that's what it looks like. But we know we can mold the shape of a head by pressure. It's a tribe that used to band, and they could band their skulls and deform them as they grew and got older into all of this. So we know we can change the shape. Some of the causes of it, torticollis is probably the number one. High percentile weight, so they just have a huge head and not very good neck muscles to move it, so they lay in one position. And then parenting habits. How much time is the kid out of arms? Are in they daycare? How are they feeding, and what's the positions? Number one is back to sleep campaign, though. If you look at the back to sleep campaign, these are some articles that started coming out that we started seeing a ton more positional plagiocephaly. They say when the incidence went up by 6-fold after the back to sleep campaign. The risk factors for it are here: Caucasians, males, prematurity, bottle fed, less educated mothers, affected siblings, and a developmental delay are all risk factors for it. So development's an interesting thing that came out with this. People started noticing that kids with positional plagiocephaly also had developmental delays more than their counterparts, 39% versus 7.7%. So then it comes into the question, well, what causes what? Does the developmental delay cause them to be in one spot and give them the positional plagiocephaly, or does the positional plagiocephaly cause compression of a portion of their brain that then causes the delay? And that's a chicken egg we still don't have teased out. We do know that we should treat it, though, because it can have effects on the eustachian tube dysfunction, visual field defects, mandibular alignment, social implications, and ergonomics. And I know this firsthand. That's my son, and that's the helmet that's 3 sizes too big for him because he had brachycephaly and had a big flat spot on the back of his head, and he's 7 years old here and still having a hard time finding a helmet that fits him. So, and then he crashed that motorcycle and broke his leg last summer, too. I think about that till I just saw the picture again. All right, so treatment of it. There's active and passive. Active would be helmets, bands. Passive would be pillows and positioning. There was a study most of you are probably familiar with in 2014 done out of the Netherlands. Everybody got hyped about it because it was a randomized prospective trial. And in the United States, this went through, and companies started banning helmets and wouldn't pay for them and wouldn't treat them. So these are some of the things that we started seeing on the internet and in different articles that after that study came out, not to use them, they should be discouraged, and all of these different things. So it's worth a second to just go over this Netherlands study. It was a government-sponsored study. It had 29 inclusion centers in it. All the orthotists were newly trained in this. It excluded anybody with torticollis, prematurity, or severe positional plagiocephaly. Remember that severe. They did measurements at 24 months by 6 different people. It was 2 different helmet companies that provided the helmets during it, and they used paper measurements, and everybody else in the world uses laser or 3D imaging. So this is just how busy they went down in their whole algorithm of things. But in the end, it's important to note, 42 people were in the helmet arm. Only 10 of them actually went to the final stage of it, yet all of them were included in the results of it. I won't get into the total minutia of it, but a very poorly done study that was obviously directed at making sure that they didn't have to pay for helmets in the Netherlands. So their thing came in and said the high prevalence of side effects, high costs, which wasn't described or reported or studied in the manuscript, and it says to moderate to severe skull deformations when they eliminated severe out of their encatchment pool in the first place. So because something says randomized and double blind doesn't mean it's still a good study, and that's what we found out is that the Netherlands aren't very good at A, doing studies, or B, correcting positional plagiocephaly. So we've had multiple arguments in our journals that show effective treatments when using helmets. So I'm not a huge proponent of helmets. I will try to avoid a helmet at all costs. Repositioning and all that early on by far does the best. A bumbo seat and a TV is the absolute best therapy for a kid with torticollis. You put them in a bumbo seat, you turn the TV on, and baby Einstein over here, and they sit there and they'll do that for 20 minutes. And they'll stretch out that neck, and you try to get a therapist to do it, and all it does is teaches kids to go like this when somebody comes at them. So a bumbo seat and a television can cure most of the positional plagiocephaly we have. So real quick on ears, ear deformities come in all shapes and sizes, microtia and just regular ear deformities. Classic treatment of microtia is with rib cartilage that we would carve a new framework, implant it. It's a 3 to 4 stage surgery. And we get ears, right? We get something that looks like an ear. Most of these kids will grow their hair out long and cover their ears over their life, right? And so even the best work that you can do, most of these have revision after revision after revision. A guy named Reinisch came out with this idea of using what's called a MedPore framework. That's what this is right here, synthetic. And you put it underneath, you put a little thin layer of tissue from the scalp over the top of it and a skin graft, and in one surgery can get results like this. And if you look at websites, it's funny, you go to any plastic surgeon's website that does cartilage grafting for ears, and you'll see the pictures. All of their kids have their hair pulled back with clips because they're covering their ears with their hair. And all the ones from Reinisch's group who I studied under to do these, all of them have short haircuts. They don't have any clips. It's kind of the funniest thing. Somebody did it in a presentation for like 5 minutes, just showed pictures and said, what's the difference? And the difference was people that grew their hair out versus didn't. So we can do this in one stage right now, and not have to go through all the 4 different ones. And then just congenital helical rim deformities that we see a lot of. These can be fixed early, right? We do the ear well system now. We mold these. Doesn't require any surgery, but it requires early intervention. You cannot start this after 6 weeks of life, where the maternal estrogens are gone from the cartilage, and you can't mold them anymore after that. So that it needs to be initiated. My preference is by 3 to 4 weeks. And that's the earwell system. They wear it for about 3 weeks, and it has phenomenal outcomes. So on that, just remember, refer early for the ear molding. Refer them in the 1st or 2nd week so we can get them, remind them to put their kid on their insurance. And then microtia, send those by about 3 months so that we can get the hearing part of that figured out and then start planning for their reconstructions. Anyway, I went a tiny bit over time. I'm sorry there, but thank you. Here's my cell phone number and email address. I love having you guys have all my contact information. If you have a kid in your practice, you want to snap a picture, you want to send me a quick text, ask, what should I do, how should I refer, or anything like that, go ahead and feel free to give me a call. But thank you very much. I appreciate it.